the last webinar on this topic, we spoke about the guidelines about classification, then what are the screening methods, what should be the screening interval, and how the referral mechanism should happen if a patient of diabetic retinopathy is detected. Now, in this talk, I am going to describe the evidence-based management that a person with diabetic retinopathy should receive based on the disease classification. Just to review what all we are dealing with, I'm just going to show you few videos. So we all know that diabetic retinopathy progresses through series of various activities at retinal level. So this video describes what all changes that take place in the retina and how it affects vision. So the initial stage of retinopathy is microaneurysms and dot and blot hemorrhages. Then there is an increase in the leakiness of capillaries bed, and there is a swelling of the retina, and there is a formation of new blood vessels in the form of neovascularization. These neovascularizations grow in the vitreous body, and because of the traction, these new vessels bleed, and there is a vitreous hemorrhage in the eye, which impedes the amount of light that is reaching retina and which leads to a positive scotoma in the eye. And a person sees something like this that you are observing on the screen. So the top image shows what a person can see when media is clear, and the bottom image shows what person will see when media gets occluded by vitreous hemorrhage. The next slide shows the video. If this is not treated in adequate time, then this will lead to a progression and will cause changes in vitreous, and there will be a fibrosis, and this will lead to an end-stage retinopathy in the form of fractional retinal detachment. So this video shows how this traction can pull the retina from its normal anatomical position and will lead to a fractional retinal detachment. So if we want to avoid a person reaching to this stage, what does evidence show? The evidence shows that if a person with a proliferative diabetic retinopathy is encountered, then we need to treat that person immediately with pan-retinal photocoagulation. There is ample evidence which is described in Cochrane review that various trials that are conducted for effectiveness of pan-retinal photocoagulation has conclusively shown that it reduces the severe visual loss by 50% at 12 months period. There is also a good evidence to show that there is a significant reduction in progression of diabetic retinopathy and occurrence of vitreous hemorrhage if a pan-retinal photocoagulation is given to a patient with PDR in proper time. So how does this photocoagulation works? So pan-retinal photocoagulation is applied in periphery as well as at the posterior pole, away from arcades of blood vessel. The main aim of giving this pan-retinal photocoagulation is to decrease the oxygen demand of retina so that these neovascular fronts that are formed will get regressed. This is given either in a sitting position by a slit lamp delivery, or it can be given in a sleeping lying down position by an indirect ophthalmoscopy delivery method also. The you can see that in the pre-treatment and post-treatment, these blood vessels are formed, which gets regressed after the treatment. What we need to counsel to the patient is the aim of the treatment is not to improve vision, but the aim of the treatment is primarily to stabilize their vision and to cause regression of blood vessel. There is an advancement in the various modes of laser delivery. The newer lasers are called as subthreshold microsecond lasers, which does not damage retinal pigment epithelium and which will cause less inflammation, less fibrosis, and they are more safer than the conventional lasers. The new laser systems are Pascal and Navilas. In Pascal, we give a multi-dose lasers at one go. The advantage of this is that it reduces the timing. This is less painful and it has shown to be equally effective than conventional lasers. The major side effect of or the problem with this is it is very, very costly. The another method is Navilas, in which this lasering is done by a integrated multimodal imaging, and here this laser is given by a camera directly. So we look at the screen and then we give laser. So it is much more comfortable to surgeon who is giving this laser treatment. But again, it is extremely costly and not used routinely in practice. The commonly used are conventional lasers, but the issue with this is that it can cause worsening of diabetic macular edema. So if we have to give this conventional laser, then we need to treat macula first, and then we have to start with this treatment. Preferably, it has to be given in 2 to 3 settings, because if we give it in one setting, there is a chance like exudative and choroidal detachment. It is always little uncomfortable to patient as well as the treating surgeon. Nowadays, especially in the United States, the proliferative diabetic retinopathy, anti-VEGF multiple injections have been approved as one of the mode of treatment. I will discuss the disadvantages and advantage of that in further slides, but this is one of the area where a lot of research can be done, and if we can be able to give an injection which can last for a longer period, then this will be one of the good treatment, because in this treatment, the side effects of laser, like constriction of visual field, are not going to happen. So, if we have to compare head-to-head between anti-VEGF injections versus laser, here we have to give repeated injection. The advantage is diabetic macular edema incidence gets reduced. The person has to visit more number of times, but the visual acuity is better in anti-VEGF group as compared to laser group. In patients who have received anti-VEGF, there is a less likelihood that the patient will need vitrectomies in future. The major risk with this is it's invasive, can cause cataracts, endophthalmitis, and third is it is costly as compared to laser. The treatment protocol for proliferative diabetic retinopathy and severe non-proliferative diabetic retinopathy depends on compliance of the patient for follow-up as well as presence of diabetic macular edema. This table describes this process in detail. If a person has proliferative diabetic retinopathy and there is no diabetic macular edema, and the patient is is likely to follow up on a regular basis, then we can think about laser PRP or anti-VEGF monotherapy within 4 weeks. If there is presence of macular edema, then we need to give anti-VEGF injection prior to photocoagulation. In case patient is not likely to be followed up on a regular basis, then we have to consider only laser PRPC as an option and not to give anti-VEGF monotherapy, because we need to follow patients with anti-VEGF on a more regular basis. And in case if diabetic macular edema is present, then we can consider giving a laser focal or grid therapy before we start laser PRPC, or it can be combined together also. Now, in case of severe non-proliferative diabetic retinopathy, if there is no macular edema, then patient, if it's from the compliant group, then only advice for regular follow-up is required. But if we feel that patient is not likely to be followed up on a regular basis, then we can give laser PRPC to that person. In case of patients with severe NPDR and diabetic macular edema, then we have to consider giving anti-VEGF or steroid injections. Generally, we prefer giving steroid injection in patients who are already undergone a lens implant surgery for cataract. In case the patient is not likely to be followed up, then we have to give a scatter laser PRP or a focal at grid if the diabetic macular edema is present. The intensity of laser has to be titrated, because in case if we give too much of a laser, then the fibrosis can increase, and we also have to consider mainly the areas which are likely to have a non-perfusion zones. So angiography can help in deciding how much to laser in patients with severe NPDR. What is the follow-up treatment in such patients who receive this laser PRP? If patients receives laser PRP, then first follow-up has to happen 3 to 4 months down the line, and if the vessels have not regressed, then we need to add more laser in the previously lasered retina. If only anti-VEGF has been given as a treatment of PDR, then patient has to follow up on a more regular, frequent basis every 2 to 3 months for at least a year, and we have to give injection based on the status of retinopathy. Now, if suppose there is a vitreous hemorrhage and it is not clearing up, then we have to recommend vitrectomy. What are the recommendations for when should we recommend vitrectomy? Early vitrectomy is indicated for people with type 1 diabetes mellitus who develop severe vitreous hemorrhage, in whom severe PDR is suspected. We can also consider early vitrectomy where PDR does not respond to extensive and aggressive laser PRP. We consider vitreoretinal surgery if on a B scan we document vitreoretinal traction with detachment of retina or threatening to detach retina. We have to give anti-VEGF injection within a week of vitrectomy to reduce risk of intraoperative complication, and we can also think of doing combined cataract and vitrectomy surgeries in patients with diabetic retinopathy and or DME with lens opacity to enable subsequent management of PTR and or DME. What we need to focus on is counseling the patient about controlling their diabetes and comorbidities, and also the outcome that repeat treatment might be required, and also patient has to be followed up on a lifelong basis. Let's look at how the vitrectomy is performed in an animated video. Generally, a vitrectomy is performed by using a scissor, and we cut those tractional bands, and then we apply endo laser so that the neovascularization gets regressed. Also, we need to give a tamponading, either internal tamponade, either gas or silicone oil, so that repeat bleeding will not happen, and whatever retinotomies that we have done will not lead to a retinal detachment in future. All these treatments have some side effects, like pan-retinal photocoagulation for NPDR or PDR, have a transient central vision loss, peripheral visual field constriction, vitreous hemorrhage, reduced or compressed accommodation, and pupillary dilatation. For vitrectomy, there could be a recurrent vitreous hemorrhage, retinal tear or detachment, vision loss, infectious endophthalmitis, and cataract. Anti-VEGF, cataract, retinal tear, endophthalmitis, worsening of traction, thromboembolic events, or intraocular inflammation. So we need to explain these in advance, take a consent, and then only we have to start with treatment. So in summary, there is a high level of evidence that laser pan-retinal photocoagulation for PDR and NPDR preserves vision. The complications are also well described. Repeated injections of anti-VEGF agents can also be effective for PDR. The complications are also well described. Which treatment is recommended for an individual patient is influenced by several factors, but principally their ability to comply with frequent and long-term follow-up for anti-VEGF agents. And there is a good evidence that vitrectomy is of a benefit for vitreous hemorrhage, but less clear for other forms of advanced diabetic retinopathy. As far as diabetic macular edema is concerned, the summary is the management of DME has, however, changed considerably over the last decades, and focal or bead lateral force photocoagulation was the only choice in the past, but now we can resort to management option in the form of intravitreal steroids or anti-VEGF agents. Again, which option is adopted needs to be based on OCT finding and whether the patient is likely to comply with frequent and long-term follow-up, as well as effectiveness of different agents and availability of the resources to deliver them. So this is a very busy slide which talks about various approaches which I have already described. So I will not go into details of this slide. Now let's look at a video how a focal laser is administered to the patient. So we have to use a lens, and then preferably for giving focal laser, angiography, if it is done with the angiography, we can identify the leaking area, and those leaking areas can be lasered, as well as we can see those microaneurysms which are leaking, and we can apply this laser to these leaking areas. This is another video which shows the focal laser treatment in the posterior pole, how it acts, how the leakage gets absorbed, and how the retina settles down. So this is the mechanism of focal or bead laser. And these are the laser spots which are given in the periphery. These are the pan-retinal photocoagulation laser marks, which are given one width apart. Generally, we have to use from 0.05 to 0.1 as a duration, and we have to aim, and then only unless and until we see where we are giving laser, we should not proceed with this laser treatment, because inadvertently, if it is given in the central part, it will lead to a permanent vision loss. This video describes the technique of giving an intravitreal injection. Commonly used is a Lucentis or ranibizumab And now various Indian
Lucentis is only to be used in accordance with approved prescribing information. Please refer to the approved Lucentis prescribing information from your country of origin. Because Lucentis is administered by intravitreal injection, proper injection procedures must be followed during the preparation, injection, and post-injection procedures to optimize patient outcomes.
has to be given in the same manner.
Aseptic technique should be observed during injection tray assembly, anesthetic preparation, and Lucentis preparation and administration. Additionally, intravitreal injection guidelines, as outlined in the Lucentis country prescribing information, should be followed. To confirm proper pre-injection procedure, verify that the patient has applied an ophthalmic antimicrobial to the treated eye 4 times daily for 3 days prior to the injection. Additionally, the patient should have had their pupils dilated in preparation for the procedure. After antimicrobial treatment has been confirmed, the injection tray can be assembled. Remember, it is essential to observe aseptic techniques, which include the use of sterile gloves when assembling the tray and throughout the procedure. Assemble the proper supplies on the injection tray. These include a sterile eyelid speculum, syringes for applying iodine and saline, a sterile caliper, sterile cotton-tipped applicators, a sterile ophthalmic drape, cotton swabs and 4x4 sterile pads, saline solution, antimicrobial eye drops if desired, and povidone iodine. Next, remove the Lucentis from the refrigerator. The vial should be refrigerated until just prior to injection. It should never be frozen, exposed to direct sunlight, reused between patients, or used beyond its expiration date. Included in the Lucentis injection kit are the single-use Lucentis vial, a 1 microliter syringe, an 18-gauge blunt filter needle identified by a purple hub, and a 30-gauge injection needle identified by a yellow hub. Lucentis should be inspected visually for particulate matter and discoloration prior to administration. Remove the cap from the vial and disinfect the stopper with isopropyl alcohol. Attach the blunt needle to the syringe. Next, carefully remove the cap from the blunt filter needle without disconnecting the blunt filter from the syringe. Then, push the needle down into the center of the vial stopper while holding the vial upright and withdraw all of the Lucentis from the vial. Leave the blunt filter needle in the vial and disconnect the syringe from the blunt filter needle. Aseptically and firmly attach the injection needle to the syringe. Carefully expel the air from the syringe and adjust the dose to the 0.05 milliliter mark. Do not wipe the injection needle and do not pull back on the plunger. Carefully remove the cap from the 30-gauge injection needle without disconnecting the injection needle from the syringe. The syringe is now ready for injection. The patient should be prepared for injection by applying anesthesia and antimicrobial eye drops. Next, disinfect the periocular skin and eyelids of the affected eye. Swab the eyelids and skin surrounding the eye with 10% povidone iodine swabs. Start with the eyelids and continue with the surrounding skin, proceeding from medial to temporal aspects, making sure the eyelid margins and eyelashes are swabbed. After disinfecting the eye area, put a sterile ophthalmic drape over the affected eye. Then apply the sterile eyelid speculum underneath the eyelids. Wash the eye with 5% povidone iodine ophthalmic solution. Be sure to cover the conjunctiva over the planned injection site. Then wait 90 seconds and wash with saline solution to remove the iodine. Now the eye is prepared for the injection of Lucentis. Direct the patient to look away from the syringe prior to giving the injection. Use the sterile eye caliper to carefully measure the scleral injection site 3.5 to 4.0 millimeters from the limbus. Insert the needle through the pre-anesthetized conjunctiva and aiming towards the center of the globe. Deliver the injection volume slowly and remove the needle slowly to ensure all of the drug is in the eye. For subsequent IVT injections, you should rotate the injection site. Now the injection procedure is complete. Post-injection, be sure to dispose of injection materials properly. Immediately evaluate light perception, indirect ophthalmoscope findings, and intraocular pressure. Finally, instruct the patient to administer antimicrobial eye drops 4 times daily for 3 days after treatment. The following is a brief review of the injection procedure. Aseptic technique should be observed during the entire procedure. Assemble the proper supplies on the injection tray. Prepare the Lucentis injection kit. Prepare the affected eye for the injection. Direct the patient to look away from the syringe and inject the Lucentis aiming towards the center of the globe. Immediately evaluate light perception, indirect ophthalmoscope findings, and intraocular pressure. That you have found this video useful for learning the proper procedures of treatment.
So after this video, the important note is that this treatment will not be effective if there is evidence of ischemic maculopathy. So we need to perform this fluorescein angiography beforehand to identify whether there is evidence of ischemia at the macula. In the absence of FFA, OCT features of ischemia like disorganized inner retinal layers, external intermediate membrane loss, and ellipsoid zone loss can be used as a guide whether treatment is of benefit or not. Now, based on these all findings, the treatment of diabetic macular edema changes whether the patient is having center involving, non-center involving, what is the leak, diffuse or focal leak, whether there is a very vitreoretinal traction, whether it is a refractory edema, and whether there is a presence of PDR and severe NPDR. The second parameter that we need to look at is visual acuity, whether the vision is good or poor. The third parameter that we need to look at is whether the patient is compliant to our advice or he is non-compliant. And fourth is who is administering this treatment. Is it ophthalmologist who is trained in diagnosis and management of DR, or it is just by a general ophthalmologist. So based on these parameters, we have to consider an individual patient and give the treatment. So I will leave this table with you to understand instead of describing what is written on it. But most important factor is that one size will not fit all. The take-home message is based on various factors, treatment of diabetic macular edema changes. And these are the factors that we need to look at when we are deciding about treatment of diabetic macular edema. The follow-up of these patients, again in the same way, if laser treatment is given, then after 3 to 4 months, If intraocular steroids are given, then regular follow-up to look at pressures and lens status. Anti-VEGF if it is given, then monthly injection. And if vitrectomy is performed, then every 2 months. What needs to be discussed with patient? Most important thing is that outcome and repeat treatment. And third is control of diabetes. So these 3 things we need to discuss in detail with patients before we undertake any treatment for patients with diabetic macular edema. Now I'm going to a condition in a patient with pregnancy. What should be our protocol for screening or treatment? So we all know that pregnancy with diabetes is that lady is more likely to develop retinopathy. That retinopathy is likely to progress faster. So their screening intervals are lesser than a routine person. Every 3 monthly, we need to see these ladies. Even we need to treat them urgently also, because that retinopathy is likely to progress faster. And what we know of is laser treatment is safe during pregnancy, but the role of anti-VEGF is not very clear and not very safe. So we should avoid giving intravitreal steroid or anti-VEGF injections in patients with pregnancy. The second most important factor that we need to discuss is management of cataract in patients with diabetes. Now we all know that diabetes is a very significant risk factor for patients with cataract. So if there is an additional retinopathy in patients who are developing cataract, in addition to cataract, then we need to treat diabetic macular edema first before we can treat cataract. We also have to ensure that the glycemic control is achieved for treatment of cataract, but what values we should aim for is still not very clear as far as patients with cataract and diabetes coexisting conditions are concerned. We also have to inform them that the retinopathy might progress and vision can go down and the outcome can be poor of our cataract surgery. So recommendation for practice is preferably a person who has cataract and diabetes, they should undergo OCT ultrasound. We need to look at iris angle for neovascularization. We also have to treat infection and defer surgery. We also have to look at endothelial cell count and a dilated retinal examination for evidence of DR, DME is must before a person who undergoes a cataract surgery. Now, if suppose there is a PDR is detected, then we can give that treatment before cataract surgery happens. But if the cataract is very dense, then we have to give it as soon as possible after surgery. The same with DME, it should be treated with the appropriate modality, either by injection or laser. And for high-risk patients of non-center involving DME, we can consider a 90-day course of nalceral anti-inflammatory topical drops like Nepafenac or Bromfenac, like that, before these patients can undergo surgery. If vitreous fever is detected along with cataract, then a combined cataract with vitrectomy with endolaser photocoagulation can be given. Now, person who has cataract and diabetes has a challenge, like there is a possibility that the pupil may not dilate fully and we need to use either iris hook or Malaysian ring Preferably, we should use hydrophobic acrylic lenses, and we need to ensure proper lens placement because there is a possibility of decentration of IOLs as well as possibility of posterior capsular opacification if lenses are not placed in its proper place. As I already discussed, the recommendation for treatment is we need to treat DME during surgery, and we need to give intracameral antibiotics to prevent endophthalmitis. Once the person undergoes surgery, we need to ensure a proper retinal examination in the further follow-ups for cataract, and based on the finding that we see during that examination, we need to treat DME or we need to treat PDR as indicated. We also may have to give longer steroids and antibiotics because they are likely to face more inflammation, and risk of endophthalmitis is more in patients with diabetes mellitus. What we are not sure of is whether subconjunctival triamcinolone or a topical non-steroidal anti-inflammatory agents with or without topical steroids can reduce the risk of diabetic macular edema after cataract surgery. So this is about a comprehensive review of treatment of DR, DME. A host of factors need to be taken into consideration before we individualize a treatment, and that is the take-home message. That although we all know that steroids, anti-VEGF injections, lasers, NSAIDs is the mainstay of treatment, but patients' social factors like whether their person is likely to comply with our advice for regular follow-up, patients' affordability, and third is patients' diabetes control history plays a major role in deciding about a treatment. So I would like to conclude by saying that we need to individualize a treatment looking at all these factors taken into consideration. Thank you very much.